All right, good morning and welcome back. You're watching Morning Cafe. And this morning, it's Health Thursday, of course. We're talking about a condition that affects millions of Kenyans, but sometimes goes misdiagnosed. And that is why we have Dr. Stephen Gigi yet again in studio to help us understand what Polycystic Ovarian Syndrome is, that is PCOS. And Dr. Stephen Gigi is the Deputy Director, Medical Services, Murang'a County, and he also doubles up as a family medicine specialist. Karibu sana to studio yet again.
Yes, thank you.
But of course, before we get deep into it, I just want to welcome our viewers to be part of this conversation. There will be a number on your screen. As always, we really love to hear from you. So on our social media platforms, also sending your questions and your comments as well at TV47 Kenya on Facebook and on YouTube. Now, Dr. I want us to start on a very basic level before we dive deep into matters PCOS, of course. We hear some call it polycystic ovary syndrome. We hear some call it polycystic ovary and ovarian. Which is which?
We refer to it as polycystic ovarian syndrome. Mm-hmm. There is a consensus that was developed in Rotterdam, Netherlands in 2003, which identified the two of the three major presentations of polycystic ovarian syndrome to be present for you to make a diagnosis. The clinical manifestation, which is seen, and also the biochemical markers, that is the androgens or the sex hormones, such as estradiol, estrogen, and progesterone, which are elevated. And then this condition occurs between the age of 7 to 15 years, that is during puberty. These people tend to have an ovulatory cycles, or they could have oligo-ovulation, meaning that occasionally they are producing the ova and other times they are not. And then a high-resolution ultrasound scan, which can be done in our level 4 facilities, demonstrates both ovaries to have the polycysts or the cystic changes. Many cystic changes that are seen in both ovaries.
Yeah.
So if someone is presenting with hirsutism, which is a heterogeneous sexual characteristic, they are women, but you find that they have abnormal distribution of hair as they develop their secondary sexual characteristics. Instead of having it in the pubic region and in the axilla, you find it in the arms. Sometimes they are developing beards in the chest. Then you need to get concerned about polycystic ovarian syndrome, especially those young girls who are obese. You see a girl is 7 years but looks like she is 13 years. So childhood obesity is a major predisposing factor. There are some genetic issues that have been associated with this condition. We have seen, even if they look normal women, and they have, when we analyze, we see that there is no alteration on the rhythm that I was talking about last time, the hypothalamic pituitary gonadal axis of hormones. Something seems to have gone wrong with the ovary. An intrinsic change in factors like we call them IGF-1, insulin growth-like factor 1, creating some even resistance to insulin. And these young girls tend to have high levels of, hyperinsulinemia. They develop the metabolic syndrome I talked about. They could be having hypercholesterol. Cholesterol levels are high. Those ones that are not useful, we refer to them as the low-density lipoproteins. And later on in life, they are predisposed to cardiac diseases, including hypertensive heart disease, ischemic heart diseases, heart attacks. So it is a syndrome.
When you talk about some of the symptoms being hair on the face, on the arms, is it a cause for alarm?
For the parent, it's good to be very keen on these conditions, because I have said the child will have obesity, that is, they are gaining weight rapidly. And then you notice that as they develop the secondary sexual characteristics at puberty, which sets in from 7 to 15 years, they might start having the hirsutism. They might have masculinization. They are having both feminization and masculinization. The lean body mass is increasing because they are producing more of those androgens. bone deposition and all that. And sometimes they have delayed menarche, meaning that the age of onset of the menstrual cycle may be delayed beyond 15 years. So those are things that should be a cause for alarm, and they need to see the doctor as fast as possible.
You've talked about sometimes PCOS coming in with irregular periods, and it starts from 7 to 15, as per what you've said. And you know, when a 7-year-old, a 15-year-old, around that age group, when somebody's just starting their periods, it's usually irregular. So how do they approach this when they don't have irregular periods when they're starting this their menstrual cycle?
Yeah, it begins at menarche in PCOS. Actually, they start having irregular periods immediately, and they are supposed to be brought in by the parents to the hospital for thorough evaluation, which will include a routine pelvic ultrasound scan high resolution to determine if they are developing the polycyst in both ovaries. And then they can be done biochemical markers, levels of estradiol, luteinizing hormone levels, which are usually elevated. And also the evaluation of the other clinical symptoms, apart from hirsutism. The masculine, they look like they are developing male, characteristics, yet they are female.
So can we attribute PCOS to a genetic component, or is it an environmental factor that now activates certain genes that now predispose women to PCOS?
I've just explained that there is studies are showing something called IGF-1 factor, that is insulin growth factor 1. These are intrinsic changes in the ovary. It seems to trigger increase in levels of gonadotrophins production in the ovary, and also increased insulin resistance, so that you have somebody with hyperinsulinemia. They are developing type 2 diabetes. If they are children, they usually develop what we refer to as maturity onset diabetes of the young body. And these are children that we see them in our diabetic clinics as well. They have glucose intolerance, they have hypercholesterolemia, and they will require to be put on treatment for type 2 diabetes also. You know, PCOS diagnosis, sometimes it takes longer. So why does it take long to diagnose PCOS? And sometimes it also has a lot of misdiagnosis with it. So what is the problem exactly? The problem is the symptomatology. You know, it is not well picked out because the child may not report anything unusual. The parent sees the child is obese. They don't see anything wrong with that. They think the girl is healthy. The development of the hair, the hirsutism, is something that the mother should be able to note while bathing the girl child. And then male characteristics developing in a young child. The child may not know because they are not feeling any pain. But the mother should be able to notice this young girl is developing both, a heterogeneous kind of sexual characteristics. Is developing both feminization as well as masculinization. And then they are brought for routine checkup in the hospital, whereby we are able to check on the levels of androgens, the estradiol levels, the progesterone, the luteinizing hormone level. Because if we leave it, they are the ones who will come to us. They usually come late because of heavy, irregular bleeding, and they are coming to us because they are unable to conceive. They have developed infertility. Yeah.
Okay. Now that you're talking about these children under their parental care, how about now people who are grown, 27-year-olds, 28-year-olds? You see somebody goes to the hospital and they are misdiagnosed with this PCOS issue. So what are some of the barriers to diagnosis of PCOS from now the doctor's perspective?
I would say maybe the availability of the biochemistry tests in the devolved unit, but we have them in our county. We are able to do tests that will help us to do a better differential diagnosis, because in these women of reproductive age, we also have to assess the TSA, thyroid functions, because that's a differential. We have to look at levels of the thyrotrophine circulating in their body. These are available. luteinizing hormone levels, we have to check, as well as estradiol, the estrogen levels. So sometimes it's missed because of the biochemical markers. But clinically, it's possible to tell somebody who is developing hirsutism. Clinically, an obese person is very easy to tell with BMIs that are above the normal range of 18 to 25. These are things that you can see. Ultrasound scans are available in our level 4 facilities. We even have portable ultrasound scans, which can pick out the follicles or the cyst in both ovaries. The 27-year-old will most likely come because they are unable to conceive. And you see, there are other differential diagnoses of ovarian cysts. We see dermoid cysts. Women with dermoid cysts will also have hirsutism. We see germ cell tumors of the ovaries, thicker cell tumors of the ovaries, mucinous cystadenomas of the ovaries. So it is not just one differential diagnosis. And we also see people who have congenital adrenal hyperplasia, which we refer to as femoral pseudohermaphroditism. So these are conditions, even Cushing syndrome, these are conditions that we see. So the important thing is to come to the hospital early enough so that we can make a proper differential and diagnosis, and also a definitive diagnosis. The reason why these people are not coming is because I've told you pain or a symptom that is causing discomfort is what will bring them. Hirsutism, people even, you'll see them displaying it on social media and they think it is a sign of masculinity, strength in the woman and all that. Yes.
You're talking about pain that causes discomfort, and you see we have endometriosis, which also comes with pain. So with PCOS, there are also some little bit of swelling, is it? So what is the difference really between endometriosis and PCOS, or do they have the same symptoms with them?
It's a common cause of secondary amenorrhea, endometriosis, and also a cause of infertility. And depending on where, this is endometrial tissue that is growing outside the normal uterine cavity. So if it is on the ovaries, they will experience pain during the time they are supposed to have their menstrual cycle. If it is in the umbilicus or on the omentum, they will still experience pain during their menstrual cycle. So this is something that we see a lot of times in young women. And again, they will have problems of infertility, inability to conceive. So we do see that. Yeah.
Do we have data on the number of women in Kenya who have PCOS? Because the global one says 1 in 10 women, and does it reflect also in the situation in Kenya?
We could be near there, but the global one points out that it's more commoner in the US among the African Americans. They see more of them having the PCOS compared to their white counterparts. But they also see that the whites, they are tending to have a delayed menarche compared to the blacks. So the age at which the whites are starting to have menstrual cycle is slightly more than the black American, African American. Yeah.
Why is that the case?
We have said there could be a genetic factor in it, which means the black population maybe have that particular genetic factor. I've mentioned about the IGF-1, insulin growth factor 1, which has been identified to cause intrinsic changes within the ovarian tissue, leading to high levels of gonadotrophin secretions, which interfere with insulin, causing insulin resistance, hyperinsulinemia, type 2 diabetes now sets in. And then they have also seen that these children who are developing PCOS may have had what we call intrauterine fetal growth retardation. Something happened in the uterus, maybe due to a maternal condition, or maybe due to a maternal disease like diseases that occur during pregnancy, like we mentioned the other time, people who may be developing gestational diabetes, deranged blood sugars during pregnancy due to high levels of circulating insulin antagonists like HPL, human placental lactogen, human chorionic gonadotrophin hormones, which encourage intracellular drive, maternal placenta barrier drive of glucose to help the growing fetus, as well as antagonizing the utilization of that glucose in the maternal circulation. So we do see that patients with PET, hypertension peculiar to pregnancy, may have babies who are smaller for gestational age, intrauterine fetal growth retardation, and later on they end up developing the condition that we are talking about.
That is PCOS.
Yes.
Okay. And when we hear PCOS, most people assume that, or just say it's only about struggling to conceive. Some say, like we talked about, irregular periods. But I understand that's not all, and you've given us some great insights on that already. But talk to us about now some of equally serious complications that come with PCOS.
One of them, like we have said, is that insulin resistance. Hyperinsulinemia will predispose this child to maturity onset diabetes of the young. And if it is not picked well, the complications of type 2 diabetes will set in. These are people who will start developing cardiac conditions, cardiomyopathies associated with diabetes. They will start having problems with eyesight, diabetic retinopathy. They will have diabetic nephropathy. They might have problems with the kidneys, damage to the basement membrane, and later on in life they might have renal failure. So we need to evaluate them thoroughly to avoid going into that direction. Diabetes peripheral neuropathy, diabetes autonomic neuropathies, all those are conditions and complications that we see diabetic feet that are developing in poorly managed or poorly diagnosed and managed maturity onset diabetes of the young. The other issues, like we have said, is the infertility. They are likely not to be able to have children.
At all?
Not at all, because there are therapies that can be given. Hormonal treatment is there to help in ovulation, because they are having an ovulation. We have medications that are routinely given, to stimulate the ovaries to be able to, follicles, to be able to produce the ova. We still give them some drugs that are used for treating type 2 diabetes, big guanides like metformin. They have been shown to, reduce or modulate the symptoms that these people are having of hyperinsulinemia. Women who have PCOS but they don't wish to conceive are put on intermittent progesterone therapy, which helps to prevent them from getting other conditions later on in life, like endometrial cancer. Yes.
Is that now endometriosis when we talk about endometrial cancer?
No, endometrial cancer is a different condition altogether. Yeah, it's an alteration of the endometrial lining within the normal uterine cavity. It undergoes an neoplastic change, mutations, and then becomes a cancer. A
cancer. So can we now say that PCOS should be treated as an endocrine disorder rather than just a reproductive health issue?
Yeah, it's a syndrome. We are already saying that it is a syndrome, meaning that it is multisystemic. When we talk of a syndrome, it is a disease that can manifest in different body systems. We are already saying that it is manifesting in terms of metabolic syndrome, glucose intolerance, hyperinsulinemia, hypercholesterolemia, cardiac conditions. And we are also saying that we can see it when we look at the Rotterdam criteria of 2003 consensus by looking at the clinical manifestations of these heterogeneous sexual characteristics in puberty, both male and female manifesting in a female and in puberty, as well as looking at the biochemical markers, the androgens, which are elevated, the LH, luteinizing hormones, estradiol, and then we look at the issue of ovulation, or anovulation. They are not producing any ova. As well as the ultrasound scan of the pelvis. So you can see it is multisystemic. Yes.
And you know, somebody maybe is watching and could be wondering, if you're talking about managing symptoms for PCOS, does it have, let's say, treatment that is permanently healed, or is it just about managing these symptoms? Can it be reversed? Well,
it is managing the symptoms mainly, because we have said there is a genetic etiology, as well as the intrinsic changes that we have said are occurring in the ovary, in the presence of a normal hypothalamic pituitary gonadal axis. So these kind of patients are treated depending on, you see, if they want to have a baby, for example, it is important that they are ovulating. So they need medications to enhance ovulation. We have them in the market. They are not expensive. We also have them in government hospitals, things like clomiphene citrate, which are given to women so that they can be able to ovulate and probably be able to conceive. A woman who has had children and still has this condition, because it can still occur in women who are conceiving, they will be put on intermittent treatment with progesterones, like medroxyprogesterone, to prevent them from getting endometrial cancer. But that does not protect them from conceiving. So they will also require combined maybe oral contraceptive pills or another form of family planning method. So you look at the whole condition. I have mentioned the use of binguanides. Metformin has been studied a lot, and it has been shown to reverse some of these conditions in polycystic ovarian syndrome.
All right. Just hold on there. We're taking a very short break at this point, but we are coming back with this conversation on polycystic ovarian syndrome. We have Dr. Stephen Gigi in studio, that is the Deputy Director, Medical Services, Murang'a County, and a family medicine specialist. Send in your questions. We'll be very happy to see them on our social media platforms, TV47 Kenya on Facebook and YouTube. Call in as well, and when we get back, of course. And we have a WhatsApp as well. We love to hear from you. So after this break, stay with us.
Our world is changing every day, and so should we, for the better. Each week, we tackle the big why, the question that should be on everyone's mind. Why isn't this fixed yet? Deforestation, global warming, and the adverse effects of climate change. The future isn't just something that we inherit, it's something that we create. Join us on The Green Fix as we tell the stories of those who refuse to give up. When it comes to fixing the planet, there is no time to waste. Join me, Shiksha Arora, on Thursdays at 9 p.m. on The Green Fix as we look into the big why, you and I.
For comprehensive information and education on your health, Body Garage is here.
Don't allow anyone to pluck out your good tooth, as long as it is strong and stable.
Cancer doesn't start today and you get the symptoms tomorrow. By the time you pick it, or the time it is manifesting in you, probably will be there about 5 to 10 years.
The eye is the window to the rest of the body.
Don't forget to stay hydrated.
And of course, you at home, do take your water.
So the ultimate test is actually you check your urine. Your urine should be clear.
Clear like the water.
Yes. Should be able to see the other side of the urine. If your urine is colored or has changed color, you cannot see the other side, then you have not taken enough water.
Don't forget regular health checkups. Early detection saves lives.
I want the message be, we can prevent cervical cancer. We prevent cervical cancer in several ways. You have young girls.
Welcome back. You're watching Morning Cafe. It's Health Thursday. We are talking about polycystic ovarian syndrome with Dr. Stephen Ngigi, a family medicine specialist, as well as the Deputy Director Medical Services, Murang'a County. And we want to invite you and to remind you that you can be part of this conversation. There is a number of your screen, call in, and our social media platforms are also on the screen. And Dr. when we talk about PCOS and the symptoms that we've already outlined, does PCOS also cause complications to the mother and to the child in cases where now somebody gets pregnant? Because we see cases like fibroids where there are a lot of complications to the mother. So does PCOS also bring this?
Yes, if they are not treated properly, they should be enrolled in high-risk antenatal care clinics, because we have talked of insulin resistance, hyperinsulinemia, and all this will predispose to other dangers to the baby. A number of these women will give birth to, because of the alteration of glucose metabolism and biochemical changes that result in it, they might give birth to a baby that is bigger than the normal, which should be between 2.5 and 3.5 kilograms. So we find they are having macrosomic babies. And these babies will tend to develop transient neonatal diabetes. Transient neonatal diabetes is where they have alterations in glucose levels. We usually screen them routinely. All babies that are born in our level 4 facilities and even the other facilities, is a routine policy that we must screen them, we must do a random blood sugar immediately, because these babies who are macrosomic are likely to have hypoglycemic episodes, which can predispose to brain injury. And then this child later on in life will have problems of growth retardation and other conditions. So there can be a problem. And
I love that you've talked about brain injury, and that also brings me to this question, because studies link PCOS to anxiety, depression, and we also have this cognitive decline. And I understand that PCOS is about hormonal disorder. Does it also affect brain health?
Well, it does, because the brain is the largest consumer of glucose. If you delay the insulin, mechanism of insulin, which increases the intracellular drive of glucose and utilization by the body cells, then you have a problem. And that's why I'm saying they start off with the transient neonatal diabetes, which macrosomic baby who is hypoglycemic. Then they can get a biochemical brain injury because of hypoglycemia.
To the mother?
To the baby. And this baby might have problems later on in life with growth, fetal growth retardation, and even injury to the brain might lead later on to generalized tonic-clonic seizures. They might start having convulsions.
How about the mother? The lady with PCOS, does it affect their brain health?
It would, because we have said that insulin also they are having high levels of circulating insulin in the maternal circulation, as well as high levels of antagonists to the insulin. So they are predisposed to gestational diabetes. You see, these are not non-diabetics, but they end up developing a gestational form of diabetes. So they are predisposed to hyperglycemia. They can have brain injury because they are not utilizing that. They are not able to utilize the glucose in the brain. They can have cerebral infarcts. And in the end, of course, the other things that we are talking about, anxiety, depression, and all that might set in.
There's a question here for you from someone watching us, and she's saying, I have PCOS, and it's a real struggle. I'm always tired, never have periods, hair sheds like crazy. I work out and it doesn't help. Mood swings, facial hair, I'm constantly hungry. The only thing doctors keep prescribing me is contraceptives. This is Vicky.
Yeah, she should visit a level 4 or 5 facility where she's evaluated for androgen levels, circulating levels of androgen, and then also assessed for metabolic syndrome, which is what is the random blood sugar in her, We can check things like hemoglobin A1C, which tells us in the 3 months has her blood sugar has been well regulated. Other medications need to be included. It's not just the combined oral contraceptive, because I have said studies have shown the role of metformin or biguanide in helping to modulate the blood sugar levels. So she shouldn't just give up. She needs to see a doctor, and more tests need to be done on her, especially the androgen levels, to determine her levels of LH, luteinizing hormone, and estradiol levels.
Mm-hmm. All right, thank you, Vicky, for that question. And you know, of course, this is also, there's also a nutritional aspect to PCOS. We hear about keto, intermittent fasting, Mediterranean diets. So what's actually the best diet for managing PCOS?
Well, the traditional African diet, where we used to take complex sugars that are, you know, they take time to be broken down in our brush border by the enzymes that are there, so that they become simple sugars that are easily absorbed in the body system. Because we are talking of obesity, childhood obesity, which will transcend into adulthood obesity or metabolic syndrome. Medications are there, but diet rich in complex sugars like millet, cassava, arrowroots, these are traditional African diets that our mothers and our grandmothers used to take, and this challenge of PCOS was not a common thing traditionally, because they were not loading the body with the sucrose. Today you find a young girl eats ice cream every day, eats a chocolate every day. They are able to access a lot of icing sugar. You know, they are taking sodas every day. They are, you know, drinking quenchers and all those kind of things. In the end, they end up with high levels of circulating, you know, glucose in the body, which will alter the body metabolism, and then they will end up with type 2 diabetes. Yeah.
So is there a danger to, or in extreme dieting for PCOS management?
Diet and exercise are important, especially for the obese ones. They need to do what we refer to as isometric exercises, because also the type of exercise you do is very important. Isometric ones include brisk walking, cycling, swimming, and jogging. Isotonic exercises are not very effective, which is like weightlifting. Those ones have not been shown to be quite good in this, because a lot of people will lift weight and then later on you will find them consuming a very high, you know, dose of a high-calorie diet. After that, they will go and eat a lot of chips. They will eat a lot of chocolate and all that.
Yeah.
And chapatis. And these are things that, you know, people eat based on the taste of the food. It is not the quality or the nutritional value of the food. People are looking for tasty foods, which have additives and all those sugars that are not of nutritional value to the body.
So is this why some of them, most with PCOS, work out but see no change at all?
Yeah, it is not unlikely to work alone. You have to combine change in diet plus isometric exercises, the ones I've mentioned, walking, jogging, riding a bicycle, swimming, and avoidance of things that are isotonic, like lifting heavy weights. That has its own problems, because if someone is diabetic, is becoming hypertensive, has a heart problem, ischemic heart disease, and they are lifting heavy weights, they are risking other conditions. Yes.
So can plant-based work? Now that you've talked about what was Zamani, they never used to have this kind of diseases. When we say we have, what are they called? These people who eat plants only, plant-based food, you know?
Cereals.
Yes.
You know, they can take cereals. Those are traditional foods. That's why I mentioned millet and sorghum. And today, it's very rare that you'll find in the young generation's meal sorghum, millet, or cassava. You see, these are complex sugars. They are contained in and it takes a lot of time for the enzyme that breaks it down in the brush border, in the lining of the intestines, so for it to be absorbed, because for it to be absorbed, it has to be converted into sucrose. Then once it is absorbed, it is converted back to glucose. by an enzyme that we find in the brush border. It's referred to as the alpha-glucosidase. Yes.
All right. There's another question here for you from Sabrina, and she's asking, can it come and go? I found out with 23 and the medical DNA analysis that I'm more likely to develop it. Last year, I gained 25 lbs for no reason. No matter how I tried, I couldn't lose weight. Periods all over the place. And yet randomly this year, I was able to lose the 20 lbs again without changing anything. So she's asking, can it come and go?
We have said the etiology could be a genetic factor, and we have said it's more predisposed in the US studies in African Americans. Diet, we have said the issue of obesity. So the family, maybe there is a family history of the same condition. So it is not something that you, what he's saying coming and going is the symptoms. What she's seeing, you know, now she sees this symptom, next time she doesn't see it. Actually, there is that category of women who will have PCOS, but they don't have the classical, the symptoms. They will have what she's talking about, irregular, long, you know, heavy bleeding, which is not following the menstrual cycle. And that is what actually brings them to the hospital, because they will be anemic. It's a difficult situation for them clinically, so they will come to the hospital. Yeah.
All right. Alice is also asking, we addressed this, but of course maybe she's just joining us, so for the benefit of Alice, is it reversible, and can you reverse it naturally?
We have said by issues of diet, just like we talk of you know, dietary changes in managing hypertension and diabetes, you may have to take more foods that are slow in breaking down. They have you know, slow sugars. They are not fast foods. Then you know, exercises that we have mentioned, and it's also important to see your doctor, because they will evaluate you and see, because I have said there are dangers there if someone has had PCOS and they are not well managed. They might end up in future developing endometrial cancer. You know, that's why they are put on intermittent progesterone therapy. Others want a child, and probably there are other interventions, like the ones we have talked about, clomiphene for inducing ovulation, use of biguanides like metformin. They do help to modulate these changes in insulin resistance. Sometimes laparoscopic surgery is done, you know, to break down those cysts, laser treatment. All this is important because they end up with infertility.
Yes. And you know, when we talk about treatment for PCOS, most doctors prescribe birth control as a first solution. So does it actually help in managing the symptoms? Does it cure? Is it treatment? Or does it just mask the symptoms of PCOS?
It does help. Combined oral contraceptive pills will help, because we are saying there are high levels of circulating androgens. And sometimes when you give the synthetic ones, they help to try and bring the normalcy, to try to make this ovary behave, because the problem we are having is an intrinsic one within the ovary, where some other factors are, increasing gonadotrophin secretions, which are not they are not conducive for allowing ovulation to take place. So the idea of introducing these ones is to try and assist so that you don't have oligoovulation, or you don't have amenorrhea with an ovulatory cycle, because that's where now the infertility is setting in.
Yeah.
Yes.
And you see, right now millions of women are having PCOS or are diagnosed with PCOS, but you see, we don't talk much about it like we talk much about diabetes, hypertension. This show on Thursday, we talk much about diabetes. Every Thursday, diabetes, hypertension. Yes. Why is that the case? We don't talk much about PCOS.
It is now becoming more important, especially with the younger generation, because they are realizing it. With the devolved units having more diagnostic equipment and having more elaborate laboratory workups, including the biochemical markers, we are now able to see we can pick out these conditions and even pick more differential diagnosis, which we were not being able to do in the past. So at level 4 facility, it's possible to pick out a patient with PCOS. Awareness that we are creating by giving these health talks, you know, our community health promoters, we are teaching them about some of the signs, the clinical signs of things like hirsutism. They should not just look at it and ignore. If they see an obese young child who has hirsutism, usually we tell them to refer them to us. And they are able to do that because this is something you don't really need a lot of, to just observe and you'll see there's something going wrong here. If a child is becoming more and more overweight, that is something somebody cannot see, and especially the mother. Then she brings them to the hospital for that checkup.
Yeah.
Yeah.
We talked about PCOS affecting the hormonal imbalances or just affecting brain health in general when we talk about now insulin resistance playing a role in this. So would you say that we need mental health support as a standard for PCOS treatment or just management?
It is very important. It's a multidisciplinary approach to handling a syndrome like this one of PCOS. It will involve even, you know, experts in adolescent medicine and pediatrics. It will involve experts in adolescent psychiatry because we are seeing it in the puberty age. It involves clinical sociopsychologists, reanimators who go to the community and, you know, sensitize people through health talks and mobilize them. We have got pediatric adolescent diabetic clinics now in our hospitals, where we are adolescent-friendly clinics are learning for diabetes. These are all the avenues that we have to try and pick out the condition to actively look out for these patients who are having PCOS and manage it before they start developing other complications, even infertility, and it becomes a major psychosocial problem. Yes.
Okay. And now that you're talking about level 4 hospitals giving treatments for or solutions for PCOS, how much more information is out there now, even for your own patients, in terms of awareness for PCOS management? Are they aware of what they have?
Yes,
what they need?
We do give health talks even in schools, in churches, when we are invited. I have seen of late even women when they are holding their chamas and all that, they sometimes invite us to give a health talk. We are encouraging people in those forums, you should engage a doctor or somebody with some clinical knowledge, a nurse or a clinical officer, somebody with some clinical knowledge and insight into some of these conditions. So that when even men when they sit in those men groups and all that, they invite us. We talk about type 2 diabetes. I have seen a lot of men inviting me in the church. We hold evening talks with them. I would like to thank the Anglican Church and Presbyterian Church. We do a lot of health talks with them for their men. They organize, and men are normally available on Friday evenings. So we discuss these things. I do even tell them to be on the lookout for their young girls if they are developing PCOS. Yes.
Is it a way of also just telling them that you need to also be aware of your wife's situation at home?
Certainly, the man has to take the lead role because he is the one directing healthcare in the household. Making sure there is a form of insurance cover for the family, at least to have SHA, because if you don't have any cover and you are going to need treatment, it will be a bit costly. Yeah.
What is the cost for PCOS treatment? Now that you're talking about cost and treatment insurance.
It will depend. You see, in level 4 facilities, it's not expensive because, giving medical therapy, treatment with medications like the medroxyprogesterone and clomiphene, those ones are available in our level 4 facilities. When it comes to laparoscopic surgery, that's a little specialized, and we have consultants, obstetrician, gynecologists who are able to do that. At least in our hospital, we have them. and they are able to do laparoscopic. So these are things that are available in some of the hospitals, some may not have. So it is important for the patient to come also for checkup. Our laboratories have been upgraded, at least in our county, so we are able to check the biochemical markers for PCOS. Yes.
We have questions for you. Kathleen is saying, I normally get pregnant, and when I'm about to turn 6 weeks or 5, I miscarry. What could be the problem?
Sometimes it could be related to genetic factors, especially those who lose pregnancies at 6 weeks and 5. Other times it could be an autoimmune disease, like we talked the other time about antiphospholipid syndrome, which is associated with recurrent pregnancy losses. They tend to have PET, or pregnancy-induced hypertension, or hypertension peculiar to pregnancy. These people will come to us after they have lost many pregnancies, and that is not good psychosocially, because it wears them down. So it is important for them to come for checkup. Other things that can cause progressive loss with gestation may be they have cervical incompetence, which can only be evaluated again in the hospitals with ultrasound scans to determine if they have cervical incompetence. Other conditions, like the way we talked of space-occupying lesions, like myomas, which are submucosal and maybe they're interfering with the pregnancy. There are people who have a problem of the luteal placenta shift is an issue also there. When they have insufficiency and they are not supported with the hormonal therapy, they tend to lose those pregnancies. Yes. All
right. Another question here from Kendi. She's saying, I went for screening after experiencing right abdominal pains and I was diagnosed with an ovarian cyst. What could be the cause? Is it treatable? That is Kendi Kanye.
Most of the times these are simple, cystadenomas. They can be treated by expectant management. You don't have to do anything to it if they have no symptoms. They only need to be followed up in their gynae clinics. If they have torsion of the cyst and it starts becoming ischemic, they will experience pain, they will have dysuria, and frequent micturition. Then that time they need to see their doctor so that an ultrasound scan can be done to determine whether it's becoming gangrenous. And at that point, maybe they will require laparoscopic surgery and removal.
And Masara Wangui is asking, can the cyst reappear after treatment? I was only 13 years when I found out I had the cyst, and it's been 7 years down the line. And at time when I put on tight clothes and press my lower abdomen on the right, it gets really painful. Is it a sign of reappearing?
I wouldn't say it is automatically a sign of reappearing, but they need to go back for a routine ultrasound check and pelvic examination to assess whether that is maybe the recurrence of the cyst, which can happen, or maybe they have another condition. Because when it's removed, they can have pelvic adhesions, risk of ectopic pregnancy. You see, we need to see them to see whether they could be developing that. The things we talked about earlier, the myomas, all these are pelvic conditions that can cause pain. But if she is feeling pain, she needs to come to the hospital. Yes.
All right. We have a lot of feedback here. Yes. And Cynthia Wanjiru is also saying, I have irregular periods, and when it comes, it's always heavy with painful cramps, which makes me sick. And I have oily skin too. What could be the problem?
We have just said that people with PCOS could have that kind of condition, irregular and heavy menstrual flow. Other conditions like endometriosis could lead to that. Adenomyosis, when they have got the endometrial tissue which is within the myometrium, then they will also have very painful menstrual flow. So she needs to come to the hospital for evaluation. Chronic pelvic inflammatory diseases that we talked last time can predispose to dysmenorrhea, severe pain. And what we have observed is that studies globally are showing a gradual plateau lies in sexually transmitted diseases. They are rising slowly globally, and it's a major concern. Diseases like syphilis, diseases like Neisseria gonorrhea, chlamydia infections, Staphylococcus aureus, Group B strep. There is a gradual increase in sexually transmitted diseases. Approach, you know, a plateau phase means you see them going up slowly, but they're not decreasing. Screening for tochesa, the diseases I told you, toxoplasmosis, rubella, cytomegaloviruses, herpes simplex viruses, or HIV, all these are important because they will determine the kind of pregnancy you carry, the risk of congenital malformations of the baby, the risk of congenital syphilis. Studies are showing there is an increase in the number of patients with syphilis. Yes. Okay.
Thank you so much, Dr. And of course, as we wind up, if you could just give one piece of advice to somebody with PCOS watching right now, how they should manage it, just anything for them.
They should visit the nearest health facility. They should not panic. If you notice that you have a young girl who is obese, developing heterosexual, secondary sexual characteristics, you should bring them to the hospital for checkup. You are the father or the mother. You shouldn't panic, and you should not ignore it, because this child could also be developing what we have talked about, maturity onset diabetes of the young. So we are encouraging people to come to our level 4 facilities for screening, for PCOS, routine ultrasound scans. When the child is celebrating their birthday, just bring them for a medical checkup.
All right, that is Dr. Stephen Ngigi, a family medicine specialist. He's also the Deputy Director of Medical Services at the Murang'a County Hospital. Thank you so much for being here yet again for this conversation on Polycystic Ovarian Syndrome. Asante sana for watching. Up next is Fitness Thursday. You're watching Morning Cafe. Stay right here.
Wow.